Good evening. Welcome to the National Hispanic Medical Association's COVID-19 Briefing Session 12, Impact on Women, Mothers, and Children. My name is Claudia Zamora. I am the founder and CEO of Zamora Consulting Group, and I also serve on NHMA's Board of Directors. And tonight, I will serve as moderator. Before we get started, I wanted to go over some housekeeping items. Presentations will be followed by a Q&A session at the end. Please type your questions in the chat box. Participant microphones and video are off and muted. The recording will be available next week on nhmamd.org. Now, I am pleased to introduce our very distinguished panel. Our first speaker is Dr. Luis Martin Gomez. Dr. Gomez, a perinatologist, is associate professor in the Division of Maternal-Fetal Medicine, Department of Obstetrics and Gynecology at Inova Health System. He is also the Director of Rotation in Maternal-Fetal Medicine at Inova's Obstetrics and Gynecology Residency Program. Dr. Gomez was born in Lima, Peru. He graduated from La Universidad Nacional Mayor de San Marcos in Lima, completed his residency in Obstetrics and Gynecology at El Hospital San Bartolomé in Lima, a postdoctoral research fellowship at the University of Pennsylvania, a second residency in obstetrics and gynecology at Eastern Virginia Medical School, and a clinical fellowship in maternal-fetal medicine at the University of Pennsylvania. Dr. Gomez also holds a master's degree in clinical epidemiology from the University of Tennessee Health Science Center. His clinical interests in pregnancy include infectious diseases, cardiovascular disease, prematurity prevention, solid organ transplants, fetal malformation, and invasive procedures. Welcome, Dr. Gomez.
Thank you, Claudia, and buenas noches. I would like to thank the organizers of this event for this invitation. Next slide. Next slide. I have no conflicts of interest, and I will present data from the CDC, WHO, FACOG, the Infectious Disease Society, the American College of OBGYN, and the Society for Maternal-Fetal Medicine. Next. And I expect that by the end of this presentation, the audience will understand the levels of COVID-19 severity, the association with morbidity and mortality during pregnancy, the socio-demographic inequalities that COVID-19 targets, and I will share the experience of the 4 largest Inova hospitals in the region, Fairfax, Loudoun, Alexandria, and Fairfax, during the pandemic. Next. As of last weekend, there were more than 230 million cases of COVID-19 reported worldwide, with close to 5 million deaths. Our region has been affected significantly in comparison to other continents. Next. And it goes without saying that COVID-19 during pregnancy is of significant relevance. Due to the relatively young age of pregnant population, pregnancy does not appear to increase the risk to acquire COVID-19, but next, not only there's a higher risk to progress into clinical illness, recurring ICU admission, mechanical ventilation, or die from COVID-19 compared to the non-pregnant counterparts, but also next, there is an increased risk for adverse pregnancy outcomes. Next. Except for miscarriage and congenital anomalies, next, almost every other pregnancy outcome is increased when COVID-19 coexists with pregnancy. As you can see in the right column, without going too deep into vaccination, you will see that COVID-19 vaccines actually do not increase the risk for adverse pregnancy outcomes compared to the background. Next slide. In the Americas, COVID-19 has affected more than 270,000 pregnant patients and caused more than 6,000 maternal deaths. COVID-19 is the leading cause of maternal death in Colombia and Mexico. In all the efforts that our Latin countries invested over the last 20 years to decrease maternal mortality have been counteracted by COVID-19. Next. In the United States, since January 2020, more than 123,000 cases of COVID-19 have been reported in pregnant patients with near 160 deaths. Next. You may remember that the months of June and July last year were very challenging for everybody. Next. The highest peak of cases was seen in December 2020 and early January 2021, likely in relationship to the recent holidays. Next. Now in June 2021, Approximately 6 months from the approval of vaccines, it seemed that the situation was getting under control. Next. But we hit another peak recently, late August and early September. Next slide. The majority of cases of COVID-19 during pregnancy affect those between 20 and 34-year-old. Next. But all age groups from teens to advanced maternal age have been affected. Next. Since the beginning of the pandemic, Hispanic pregnant patients have been preferentially the target of COVID-19. And currently, cumulative data show that also women of white race appear vulnerable after the Latino group. Next. What we have learned so far since the beginning of the pandemic is that the approach to COVID-19 during pregnancy is essentially similar to outside of pregnancy with regards to prevention, evaluation, management, therapeutics, and immunization. Next. The classification of COVID-19 severity in pregnancy is the same as outside of pregnancy. Mild cases have symptoms that resemble a common cold. Moderate COVID-19 represents lower respiratory tract disease with worsening symptoms and radiographic evidence of pneumonia. Now, please note that in this category, pregnant patients can have lower oxygen saturations than the target of 95% that is recommended during pregnancy. Next slide. Patients with severe COVID-19 and very tachypneic have very low oxygen saturations, wider lung area involvement, and are in need of high supplemental oxygen. Those with critical illness have multi-organ failure and usually are in need of mechanical ventilation. Next slide. Compared to non-pregnant patients, those who are pregnant are at increased risk for preterm delivery, worsening to severe critical disease and maternal death. Next slide. A recent publication showed that the main risk factors for worsening COVID-19 during pregnancy are, next, advanced maternal age more than 35 and especially more than 40, diabetes mellitus, more than one pre-existing condition. And please note that healthcare pregnant workers also are at risk for worsening illness. Next slide. In a recent publication, Center from the Maternal-Fetal Medicine Unit Network reported that approximately 3 out of 4 pregnant patients are asymptomatic, positive for hot mild disease, with only 12% progressing to severe or critical illness. Next, from our experience at Inova from last year, more than 90% were asymptomatic or mildly affected, and only a small fraction, less than 2%, has severe or critical illness. Next slide. Of all pregnant patients with severe forms of COVID-19 in the US, only a fraction will require mechanical ventilation. Next slide. This chart is to illustrate that the treatment of COVID-19 is stratified according to the severity and targets its underlying pathophysiology. Next. For mild cases, antibodies cocktail, monoclonal antibodies, and convalescent plasma have shown to reduce the risk of progression and hospitalization. Next. On the opposite side, dexamethasone has shown to reduce mortality, likely by aiming to decrease inflammation. Heparin or enoxaparin reduce the risk to develop thrombosis, and remdesivir holds viral replication, especially in patients with severe illness. The same approach is applicable to pregnancy. Next. Very importantly, non-pregnant patients with moderate COVID-19 who have oxygen saturation of 94% usually do not require oxygen supplementation, dexamethasone or remdesivir. For this reason, even in institutions at the beginning of the pandemic, pregnant patients with moderate COVID-19 with oxygen saturation of 94% and very tachypneic were not offered oxygen supplementation or observation and were discharged or treated with antibiotics for presumptive pneumonia. And as you can expect, many of these patients returned to the hospital with worsening disease. Next slide. But in pregnancy, it is recommended that the oxygen saturation be maintained at 95% or higher. Next slide. This observation intrigued us at Inova, and we postulated that pregnant patients who present with moderate COVID-19 symptoms should receive oxygen supplementation to prevent worsening disease and prolonged hospitalization, and should receive treatment with remdesivir or steroids. We published our findings earlier this year. Next slide. We noticed that patients with moderate COVID-19 in the upper graph, next, that started remdesivir within 48 hours of admission, next, decreased their demand for oxygen supplementation within 48 to 72 hours, next, and by the end of treatment, they were stable for discharge. On the contrary, those who started remdesivir more than 48 hours from admission, depicted in the lower graph, next, would continue with high demand of oxygen, next, even after finishing the 5-day course of remdesivir, next, and had prolonged hospital stay. Next slide. In blue, you can observe that starting remdesivir within 48 hours of admission in pregnant patients with moderate COVID-19 was associated with a faster clinical recovery than when remdesivir was started more than 48 hours from hospitalization in red or not used at all in green. Next slide. We also became interested in the effects of COVID-19 in teen pregnancies. Next. Nationwide, the prevalence of pregnant adolescents infected with COVID-19 in 2020 was approximately 4.5% of all pregnant individuals. Next. And compared to non-adolescents, pregnant teenagers have less risk for preterm delivery. Next. Or to require cesarean. Next slide. In 2020, the prevalence of adolescents infected with COVID-19 in our largest 4 hospitals at Inova was 6.5%. Next slide. With the premise that in non-pregnant individuals, teenagers with COVID-19 are less likely to develop the most severe form of the disease, we compare outcomes of pregnant adolescents to pregnant adults in the year 2020. Next. Pregnant adolescents with COVID-19 were more likely to be Hispanic, 91% versus 74%. Next. And less likely to be premature when diagnosed with COVID-19. Next slide. Pregnant adolescents infected with COVID-19 were more likely to be asymptomatic, next, compared to the adult counterparts. Next slide. Now, within the overall pregnant adolescent group, with the premise that COVID-19 is associated with poor obstetric outcomes compared to non-infected individuals, we compared the profile and outcomes of pregnant versus non-pregnant adolescents. Next. Pregnant teenagers infected with COVID-19 were much more likely to be Hispanic, 91% versus 12%. Next. And to have no medical insurance with limited access to healthcare facilities compared to non-infected pregnant teenagers. Next slide. Adolescents infected with COVID-19 were more likely to deliver by cesarean. Next. Compared to pregnant adolescents, but other obstetric outcomes were not significantly different. Next slide, please. Also, in our experience at Inova last year, we noted that certain routine interventions that are utilized in non-pregnant individuals with severe forms of COVID as prone positioning can be applied safely in obstetric patients without any negative impact. Prone positioning is known to help avoid intubation in patients with severe COVID-19, is feasible, and is not contraindicated in pregnant patients with mechanical ventilation. Next slide. A common question we get from patients is how COVID-19 can affect the unborn or newborn. As of now, there is no solid evidence that the virus can be transmitted through the placenta or breast milk. Breastfeeding is safe, but we also know that the risk of perinatal death may be increased in infected patients. Next slide. Basic measures as wearing masks appropriately, frequent hand washing for 20 seconds, and cleaning surfaces should be the norm. Next slide. In addition, it is important to wash hands before manipulating breast pump and bottle parts, and do not place a mask on the newborn. Next slide. Finally, the same basic measures as wearing masks, social distance, and respiratory hygiene remain powerful tools against transmitting and acquiring COVID-19 during pregnancy. Next slide. And don't forget to contact your provider or local health resource for questions. Despite all widespread information, you should trust your healthcare provider. Next slide, please. I hope that in this presentation I was able to convey to you that pregnant patients, especially those with pre-existing risk factors, are vulnerable to COVID-19 and can quickly escalate into the worst forms of the disease. And the steps to stay healthy during pregnancy and breastfeeding are the same as those used outside of pregnancy. Thank you very much for your attention.
Thank you, Dr. Gomez. Our next speaker is Dr. Annalia Graciano. Dr. Graciano is Professor of Pediatrics at the University of Maryland School of Medicine and a senior attending physician in the Division of Pediatric Critical Care at the University of Maryland Health System, where she also serves as medical director of the PCICU. Originally from Argentina, she completed her critical care training at Massachusetts General Hospital, Harvard Medical School, and at Children's Medical Center of Dallas at UT Southwestern Medical Center. Dr. Graciano is a member of the Overcoming COVID-19 Investigators, a research network aiming to understand the mechanisms and management of this devastating disease in children and young adults, and has lectured extensively on the impact of COVID-19 in children. She has been an active member of the Pediatric Acute Lung Injury and Sepsis Investigators since their inception in 2002, collaborating in multi-center studies aiming to identify preventive and therapeutic strategies for sepsis, acute lung injury, and other systemic inflammatory syndromes in critically ill children. She participated in the development of and co-authored the American College of Critical Care Medicine Pediatric Sepsis Guidelines, and has led several initiatives to improve pediatric sepsis at her workplace and beyond. She is a member of several national and international medical societies and is a recipient of several awards for her contributions to pediatric critical care. She recently co-founded Pilates, a network of Latin American pediatric intensivists whose aim is to expand collaboration, knowledge exchange, and educational activities throughout the Americas. Dr. Graciano is board certified in pediatrics and pediatric critical care medicine and is a fellow of both the American Academy of Pediatrics and the American College of Critical Care Medicine. Welcome, Dr. Graciano.
Thank you very much for that kind introduction, Claudia, and thank you everyone for being here this evening. And it's really an honor to share the panel with Dr. Gomez and Dr. Rimola. So yeah, I'm a pediatric intensivist. I'm not an infectious disease specialist, and I am not a vaccine specialist, but certainly I have seen a lot of COVID since the pandemic started in the ICU, and I will give you a little overview of what happened with kids. Next slide, please. I have nothing to disclose. Next one. So here are the objectives of my talk are to describe the trajectory of COVID in kids, describe the characteristics of MScE, which not everyone is familiar with, and discuss the current knowledge of the only FDA-approved COVID vaccine, which is the Pfizer vaccine for kids. Next. So it's hard to believe that it's been almost 2 years since this pandemic started. And if you look at the first line there, December 29, 2019, was when the first case of a pneumonia of unknown etiology was reported in China. By the end of January, a month later, the death toll was above 130,000. In mid-March, the WHO declared a pandemic. At that time, adults were dying and cases were increasing tremendously. But really, we did not see sick kids, and we did not see COVID at all during the beginning of the pandemic. Next slide. There were many reports highlighting the characteristics of COVID in children. In reality, everyone was reported that the cases were milder and the kids had better prognosis, and we all thought the kids were all right. And in general, they are all right. Next. So maybe they are all right or maybe not, because there are some kids that really can get very, very sick. Next. So by late April, there were clusters of children that were being admitted in different places in different ICUs and pediatric wards around the world. England, Italy were some of the first ones reporting this unusual illness. So they had a constellation of symptoms that are highlighted here. From this, the ones that I like to highlight is the fever, that most of the kids had fever. Some did have and did not have sore throat. The abdominal pain was very typical, and many kids present that way and with vomiting and diarrhea. Sometimes they present with symptoms that look like an acute abdomen. And then some kids had skin rashes, and most of the kids had some degree of myocardial dysfunction, and they did have elevated markers of inflammation. And initially during the pandemic, what we saw is the majority of these kids had PCR negative for coronavirus 2, but they did have positive antibodies, reflecting that the kids had been exposed to the virus, did not get sick during the acute event, but several weeks later, they were presenting with this inflammatory syndrome. Next. So the first, one of the first papers was from England and was published in Lancet in May 2020. And they reported 8 kids that presented with kind of Kawasaki-like, but it was not really Kawasaki disease. These kids were very sick. They did have myocardial dysfunction. One child died, the other one survived. From then, there are multiple papers if you search MScE of different centers reporting this syndrome. Next. So the CDC highlighted the case definition for MScE, which is shown in this slide. So initially the age was 18 years or younger, and they changed it to 21 or younger, with fever, laboratory evidence of inflammation, and evidence of clinical severe illness requiring hospitalization, not specifically ICU, just that they have to be in the hospital, and multi-system organ involvement of at least 2 organs. The most common that we see are cardiac and GI. And hematologic, we see kids with thrombocytopenia. And certainly the ones who present with more severe disease can have acute kidney injury, and we have seen encephalopathy as well. And again, many kids have PCRs positive for COVID, especially now with the Delta variant. We are seeing a combination of acute COVID with MScE. Initially, their PCRs were negative, but they did have antibodies. And although the CDC highlights the exposure to suspected or confirmed case within the 4 prior weeks, in reality, many patients, they don't even know they were exposed, at least initially. Next. So these are on the left of the slide, you can see the laboratory that the abnormalities that we see in MScE, and on the right, some of the studies that we ordered and the abnormalities that we see as well in the echocardiogram and the lungs. So from the left, the most important, they are all important, but lymphopenia is a marker of more severe inflammation. Thrombocytopenia is common, and the elevated markers of inflammation, a combination of these markers that are highlighted there, and the most common are D-dimers, elevated CRP, in some kids had really high fibrinogen. No, everyone gets interleukin-6, and so that's not the standard initial lab that people order in a patient who has been admitted with COVID, in the pediatric patient admitted with COVID. And they do have elevated cardiac markers, and the echocardiograms, and most of these kids have some degree of cardiac dysfunction, from minor to severe, that require inotropic support. And the chest X-ray can be normal initially and then develop infiltrates. The other thing is, many of these kids, because of the abdominal symptoms, they have CT scans or ultrasounds that were done, and they found bowel and mesenteric inflammation. And in fact, our first case of MScE, when we didn't know that much about the disease, presented with abdominal pain and was transferred like it was an acute appendicitis, and it was a post-COVID inflammatory syndrome. Next. So here I'm just showing you that the kids really are all right, but they are not all right, because the ones that get sick can get really sick. On the upper level, you can see on the left, That's a patient with MISC that was initially admitted without oxygen requirement and with a pretty normal chest X-ray. That the X-ray on the right is the same patient 36 hours after being in the hospital, where you can see the patient has the X-ray shows cardiomegaly and pulmonary edema, and the patient requiring nootropic support and additional support for MISC. And on the bottom, you can see some CT scan. And even if you're not a radiologist or an intensivist and you're not familiar with CT scans, it's obvious that these kids have severe lung disease. So again, the kids are all right most of the time, but not always. And the ones that get sick can get very sick. Next. So our group, the Overcoming COVID-19 investigators, have published several papers, but one of the first ones was we were trying to figure out what happened with MISC in what we saw next was during the lockdown period, as the COVID cases were decreasing, the acute COVID cases were decreasing next, the MISC cases were increasing. So these kids were exposed to COVID at some point, few weeks before. And as the acute infections were declining, we started seeing more and more kids throughout the year. Next. So the burden of COVID-19 in children is real. It's true that in general, they do better. It's true that fewer kids are infected. It's true that not that many kids died, like Dr. Gomez showed the adult mortality. But there are over 5 million pediatric cases reported in the United States. Kids who are healthy can get sick, and certainly the ones that have underlying medical conditions are even sicker. There is a high incidence of cardiovascular involvement, and this is important because of the concern with the vaccine, which I'm going to refer. And the other thing is I want to highlight from here is the racial disparities, which is similar to what Dr. Gomez presented, which the hospitalizations in kids are higher among Hispanic and Latinos. And again, although the mortality is much lower, still exists. Next. This is from the CDC from last week, a report of pediatric mortality. The light blue is kids, mortality in kids 0 to 4 years of age. In the darker blue is 5 to 18, which is more common. We see those kids more than the younger ones. So yeah, over 1,000 kids have died. That's a 0.02 to 0.03% mortality, which we can say in some other illnesses it's negligible, but this is mortality, pediatric mortality that shouldn't happen because we should be able to control this disease with immunizations and other measures. Next. So the vaccine was developed, the vaccine was approved initially for adults, as you all know, and now we have one vaccine in the United States that has been approved for kids, and it's the Pfizer vaccine. It's an mRNA vaccine and was approved for children over 16 years of age in August, and there is an emergency use authorization from the FDA and to vaccinate kids from 12 to 15 years. And now the study is looking at younger kids. The regimen is similar to the one in adults, 2 doses, 3 weeks apart. The concentration of the vaccine is lower for younger kids. And the optimal protection, similar to the adults, is after 7 days of the second dose. The Moderna study is ongoing. We don't have enough data, so I'm not going to expand on that because we don't have that vaccine yet for kids. Next. So the side effects of the vaccine are, these are the common side effects, like the adult, basically. Pain at the injection site, fatigue, headache is very common, and lymphadenopathy can be common. And some kids, it has been reported in girls, adolescent girls, syncope, in girls without myocarditis, but there are some reports of syncopal episodes. Next. So the vaccine was being administered to children, there were multiple reports of acute myocarditis cases following mRNA vaccination, mainly in the United States with Pfizer, obviously, because that's the only one we are giving. In the paper from the last paper is a case series from Boston Children's, where they look at all the patients that were vaccinated, and they found and were admitted with myocarditis, and they found an association, like a temporal association of the vaccine, of myocarditis with the vaccine. Next. So myocarditis and COVID vaccine. So during the initial study, myocarditis was not seen or was not reported. There were many just like very isolated sporadic cases. But post-marketing data does demonstrate that there is increased risk of myocarditis and pericarditis, especially with the second dose and a week after the second dose. The incidence is low if you think the amount of vaccines that are being administered and the number of cases that we are seeing. It is more common in males, in young males, in the ages they are certainly adolescents with myocarditis have been admitted for observation. The clinical and laboratory presentation is the same as any other myocarditis or pericarditis. They present with chest pain, they present with palpitations, shortness of breath, and they have elevated cardiac markers. And the EKG can show ST elevation and some other abnormalities. Some kids have presented with arrhythmias. In cardiac MRIs suggest myocarditis. Most of these kids have resolution of the symptoms just with conservative management. They're given non-steroidal like ibuprofen or Motrin. They are monitored because we don't know that much about this illness yet. But they seem to respond very well and recover completely, at least for the short term. We don't know the long term of effects of this event. Next. Here, I'm just highlighting, if you go to the CDC website and search the acute myocarditis in children related to mRNA vaccines, you will have the definitions for probable cases, confirmed cases, and the same for pericarditis. And I won't expand on this because I think we're running a little bit out of time. Next. So we do know the kids get sick. We do know they can get very sick. We do know that some kids die, and we do know that we can vaccinate these kids, and that the ones that had side effects from the vaccine don't get as sick as if they were going to get COVID and have myocardial dysfunction. So in summary, fewer cases of COVID-19 have been reported in children compared with adults, but the number and rate of cases have been still increasing since March. And right now we are seeing many more than last year. Myocardial in unvaccinated kids. Myocardial dysfunction and elevated cardiac markers are common in children with severe COVID and with MScE. And myocarditis associated with mRNA vaccine has been reported, as I show you. Most of the cases are occur after the second dose. Most of the cases seem to be mild and respond to ibuprofen or Motrin, like I mentioned. There is no specific therapy for myocarditis. The care is supportive. And again, the kids have to be monitored like if you were an adult, because the possibilities of arrhythmias or additional cardiac dysfunction, certainly they require hemodynamic monitoring or at least cardiorespiratory monitoring. There were some cases of myocarditis and pericarditis after the first dose of mRNA vaccine. And if a patient had that, they shouldn't get, the recommendation is that they should not get the second dose. And that may change over time, but we really don't know. Next. So the American Academy of Pediatrics in many other associations recommend vaccination for COVID-19 in all populations for which a benefit has been established as benefits of the vaccine outweighs the risk. And there is no doubt that vaccinating kids who do not have contraindications for the vaccine has a benefit, because if they get COVID, they can be okay, but many kids are not okay. And certainly there are many questions that remain unanswered and are listed there. I think as we learn about this disease, I think if we have this same webinar in a year, we may have different information, because certainly we learned over the last year that COVID can be a serious illness in pediatrics as well. And with that, I close, and I apologize, I went a little over time. Thank you. Next. Thank you very much for your attention. And that's my email if you have any questions or need to contact me. Thank you. No. Well, those were slides from, we don't need to show them, from the
Hey, Ariel, can you go to Dr. Rimola's presentation, please? Oh, I'm not seeing it. Oh, I'm sorry. Okay. Thank you, Dr. Graciano. Our final speaker is Dr. Sergio Rimola. Dr. Rimola has served as attending physician of obstetrics and gynecology at Inova Fairfax Hospital since 1997 and holds a part-time position at Inova's OBGYN clinic, serving mostly underserved and uninsured patients. Dr. Rimola has faculty appointments at the George Washington University's School of Medicine and Health Sciences as clinical instructor in the Department of Medicine. He also holds faculty appointments at both the University of Virginia School of Medicine and Virginia Commonwealth University's School of Medicine as Associate Clinical Professor of Obstetrics and Gynecology, serving as a preceptor and mentor for medical students, residents, and nurse practitioners. Originally from Guatemala, Dr. Rimola graduated from La Universidad de San Carlos de Guatemala and completed a residency program in obstetrics and gynecology before migrating to the US. He also completed a residency program in obstetrics and gynecology at Sisters and Charity Hospital, affiliated with SUNY at Buffalo. He's a board certified member of the American Congress of Obstetrics and Gynecology since 1993 and a board member of the Virginia Latino Advisory Board since 2015. Currently, he's a member of the Northern Virginia AHEC Advisory Board, the Fairfax Health Department Multicultural Council, and a board member of Valhan. Dr. Rimola also serves as chair of NHMA's DC Metro Region chapter. Welcome, Dr. Rimola.
Good evening. Thank you so much for the introduction, Claudia. Buenas noches a todos. On behalf of the NHMA DC Metro chapter, I would like to thank you, Dr. Luis Gomez and Dr. Annalia Graciano, for being speakers tonight for the excellent presentations. As a disclosure, I don't have any conflict of interest. And today I'm going to focus mostly on COVID-19 vaccines in pregnancy and overview and evolution of the topic up to date. Today, I just received a fax from CDC with an urgent action to increase COVID-19 vaccinations of pregnant people. The highest number of COVID-19 related deaths in pregnant people, 22, were reported in August of 2021. The Hospitalization Surveillance Network, COVIDNet, in 2021 reported that approximately 97% of pregnant people hospitalized with COVID-19 were unvaccinated. Here, it is extremely important as a physicians that we encourage our patients to get vaccinated in order to protect from this disease. The data indicate that pregnancy is an independent risk factor for severe COVID disease. This has been already presented by Dr. Gomez. Our Hispanic, Latin, and Black patients are disproportionately affected by severe maternal mortality, and they have an increased also incidence of COVID-19 infection and death. Next, please. At the present time, we have the 2 or 3 vaccines that have been, 2, they have emergency authorization, and 1 has been fully approved. We have the messenger RNA vaccines. Currently, we have the Pfizer and the Moderna vaccines. They use the genetic material that encodes the SARS-CoV-2 spike S protein that elicit neutralizing antibody responses to the S protein and will confer superior protective immunity compared with the M protein targeted antibodies. These vaccines, they don't have a live virus. They have a rapid degradation, and the material that is injected will disappear in a short period of time. Therefore, there is no risk of genetic modification for people receiving the vaccine. Next, please. The Johnson & Johnson vaccine uses adenovirus. It's very similar also to the AstraZeneca in order to carry the gene for the coronavirus spike S protein into the host cell to produce for a spike protein. This vaccine has not been used as many in pregnancy as the messenger RNA vaccines. And as you all know, in April 13, 2021, the US FDA and the CDC recommended a pause in the vaccine because there were some severe cases of blood clot that was called cerebral venous thrombosis. And also TTS, is a thrombosis with thrombocytopenia. This condition is extremely rare. And after a pause, the vaccine was again recommended with some warnings. Next, please. This vaccine, as you know, they are highly effective. The initial data, the Pfizer vaccine, 95% effective. The Moderna, very similar, 94.1. So we know that these vaccines are highly effective, producing antibody titers in pregnant and lactating women. Also, their protection in pregnant, we know, is very high. However, when we have the Delta variant, we have a game changer. We have seen that the vaccines are not as effective as initially with the initial variants. The Pfizer has is as effective from 42 to 96%. Moderna has a little bit higher effectiveness of 66 to 95%. However, these vaccines may be not as effective to prevent COVID-19. However, they still are highly effective to keeping patients from going to the hospital or death. The data that was released on July 28 with the booster vaccine that now has been approved for certain patients has demonstrated that they give a good protection against the Delta variant. Next, please. As you all know, that pregnant women were not included in the clinical trials of COVID-19. Despite the fact that several organizations such as the Maternal-Fetal Society of Medicine and also the American College of OBGYN, they advocate for inclusion of pregnant women. They were not, because there is very difficult to do studies in pregnant women because there is always the concern for the fetal risk and not in consideration for the risk of the dad and the mom. This situation va a ser cause of producing a lot of hesitance and has led to inconsistent policies. Next, please. During the initial rollout of the vaccines on December of 2020, there was not a clear guidance and recommendation during pregnancy and nursing. It was not until the month of March that we have, with the MScE program from CDC, we have several patients that they were pregnant, particular health providers, nurses, doctors that have been receiving the vaccine, and there was no identification of any significant side effects or outcomes after 827 pregnancy that have been already completed. Next, please. Based on this initial data, CDC recommended that pregnant women could receive the vaccine, but it was not a strong recommendation. The American College of Obstetricians and Gynecologists and also the Society for Maternal-Fetal Medicine, also they say that pregnant women should have access to the vaccines, but they did not provide a strong recommendation yet. They suggested that patients should have a discussion with the providers and the decision should be up to the patient after putting all the benefits and risks. This conversation was not necessary prior to that will require vaccination. Next, please. The CDC Advisory Committee on Immunization Practice, SCIP, start reporting several cases of pregnant women up to 139,000, which now we have more than 160,000 of self-reported in the MScE program, and there have not have been any side effects different from those people of the general population. In addition to that, there have been about 4,000 patients that have been followed, and there has not been any different outcomes such as miscarriages, stillbirth, pregnancy complications, ICU admissions, adverse birth complications, neonatal death, infant hospitalization, or birth defects were very similar. Next, please. We don't have a lot of information with the Johnson & Johnson vaccine. There were some patients that they were placed in the study that were already pregnant. However, these vaccines have been used in the past, such as in Ebola, and they have been to prove not to have adverse pregnancy outcomes. Actually, now we have some studies ongoing from Johnson & Johnson and also Pfizer in pregnant volunteers. Next, please. On August 9 of 2021, 20 leading organizations, including the American College of OBGYN, the National Hispanic Medical Association, the Maternal-Fetal Medicine Society, and several other organizations, strongly urging all pregnant individuals, along with recently pregnant patients, to get the vaccine. However, it was not still an official recommendation. We found that with the Delta variant, we have an increased risk of severe COVID disease, and therefore, these vaccines are proved to be safe and effective when they're administered in pregnancy. Next, please. On August 11, the CDC considered that these vaccinations are safe for pregnant women after reviewing all the data. The CDC director, Dr. Rochelle Walensky, encouraged all pregnant people or people who are thinking about becoming pregnant or those who are breastfeeding to get vaccinated to protect themselves from COVID-19. There was an initial data of 2,500 pregnant women that received the messenger RNA vaccine before 20 weeks, and there was no increase in the incidence of miscarriage. It was approximately 13%, as opposed to the normal population is between 11 and 60%. Previous data from other safety systems also did not found any increase in miscarriage. Next, please. This study was published, this information was published in the New England Journal of Medicine on September 8th. Is the study that I mentioned about 2,500 participants. The risk of a spontaneous abortion was very similar as expected in the normal population. Next, please. This is just the graphic. Next, please. After the approval of the full approval of the Pfizer vaccine, more physicians were likely to talk to the patients and become more confident recommending vaccination for the patients, including pregnant patients. Once again, those organizations, 20 organizations, including the American College of OB/GYN, the Society of Maternal-Fetal Medicine, the CDC, they now recommended that all pregnant women should get vaccinated against COVID-19. The vaccine in pregnancy is safe and effective, and is the single best tool that we have to protect us individual and fellow members of our communities against COVID-19. Next, please. With respect to the side effects, there was a prospective study that was on January 20, started on January 2021. Several hundred patients that received the Pfizer and Moderna vaccine. Basically, most patients, they report side effects that they were mostly pain in the injection site, fatigue, and occasionally some fever. However, between the pregnant patients and patients who are not pregnant, the side effects were actually very similar. And in fact, severe reactions were statistically significant decrease among pregnant individuals. Next, please. Next, please. We have seen the news and recently the hospitals that Dr. Gomez already mentioned. This hospital, the University of Alabama and Birmingham, they reported on August 39 patients that were admitted to the hospital with pregnant patients with COVID-19. Of these, 10 pregnant were admitted to the ICU and 7 patients were intubated. Normally, this unit will have 1 pregnant patient admitted to ICU. Also, there has been an increase in COVID-19 stillbirths in Mississippi, and this is related that those states, they have very low rate of vaccination. Next, please. Just a study that was recently published in the American Journal of Obstetrics and Gynecology. 64 vaccinated patients and 11 patients that have the COVID-19 during pregnancy, natural infection. There was a significant higher SARS-CoV-2 IgG levels in maternal serum and cord blood among vaccinated women. So the amount of antibody is much higher in those patients that are vaccinated than those patients that they have the COVID-19 disease. This is given additional benefit of the vaccine, since not only giving maternal protection against COVID-19, but the vaccine also is providing neonatal humoral immunity, what is very important. The same can happen with breastfeeding. Next, please. This is just the latest data that we have for patients who are getting vaccinated. Actually, this is updated to up to the 27th of September. 161 reported pregnancy as they have been recorded in the BSAFE program. All the races, we have 25.2 vaccinated, what is still very low. Hispanic, Latino, 21.4, white, 27.3. The lowest is Black population, only 13.8. I have been watching these numbers. I see a little increase every day. So I think so we are getting a little bit better, but we are still lagging in pregnancy. Next, please. So as you can see, we have still a lot of vaccine hesitance because the message from the beginning has not been very strong about the recommendation and the fact that pregnant women were not included in the initial clinical studies. As a physician, we have the responsibility to talk to our patients in a cultural and linguistic competent way to convince them of the benefits of getting vaccinated against all the risk of COVID-19. And that can happen to the women, also to the fetus. We have to use positive motivation. We have to take our time. When we see a pregnant patient, we have to start initiate a conversation. And if the patient definitely doesn't want to get vaccinated, we can ask what are the reason why she doesn't want to get vaccinated. We have to be very empathetic with them. We have to try to get to the roots of the hesitancy, and the patient is still not sure about the vaccine. We can come back in the next visit. We have to build the trust, patient trust medical providers. We have to be able to talk to them and show what the benefits of the vaccine are, what will be the, what is going on now with the Delta variant, you know, that we have ICUs getting packed with patients that are pregnant. Thank you very much.
Thank you, Dr. Rimola. Now we have a couple of minutes left to answer some questions. The first question, do we have any estimates of the incidence of post-vaccine myocarditis versus incidence of myocarditis after infection? And I believe Dr. Graciano is gonna provide the answer.
I don't have an answer, but it's, I will, but we don't have the information. That's, the question says, you know, harder, of course, to quantify since most infections go unreported. That's one very good point. And also, we don't have enough information yet about the post-vaccine myocarditis. What we do know, there were some studies that they did, for example, cardiac MRIs in young, in adolescents, basically, who had COVID, even if they had mild disease. They were not very sick, they were not in the ICU, and they had, based on the severity of illness that was presented previously, they had relatively mild disease. Some other ones were sick. In 60% of those patients with who had COVID show cardiac inflammation in MRI. Of course, you cannot train everyone because it doesn't make any sense because they recover. In general, these patients are, if they have severe disease, they will have echocardiograms and eventually they will have a cardiac MRI, but the ones who had mild disease don't get, at least the kids don't get all that high screening. But so we do know the virus causes inflammation in different organs. And we do know that the heart is affected by the virus at different levels of severity. And certainly the patients who get COVID, the children who get COVID and have myocardial dysfunction, they get very, very sick. Some kids, not only they require inotropes, some kids go on ECMO, require extracorporeal life support, and of course, some kids do not survive. We do know so far that the kids who are vaccinated and do have a myocarditis related to temporarily associated with the vaccine, their disease is mild. But we don't know, I guess, perhaps in a year we will have more answers, but we don't have it yet. That's a very good question. Thank you.
NHMA, do we have time for one more question or are we out of time? Okay, seems that we've run out of time. I would like to
keep going, Claudia, if you'd like. We can do 10 more minutes if you can.
Okay, let's see. Next question for any of our panel. Would any of you recommend that workplaces requiring vaccine mandates, such as schools, hospitals, military, and so forth, include pregnant women?
Well, go ahead, Sergio.
I believe that mandates are is a good thing to do, like for teachers, for healthcare workers. I think for pregnant women, I will still not recommend it, because the issue patients, a lot of times they are worried about that the vaccine may affect the baby. They have to take their own decision. And also there is another question that might be related: which trimester patients should have the vaccine? And that can be, the vaccine can be given any trimester of pregnancy. As soon as patient is pregnant and they have not been vaccinated before, they should do it. And also the same question, I think they are asking about the reported menstrual cycles irregularities. It has been reported, however, it seems to be something that is very transitory and doesn't have any long-term consequence.
I agree, Sergio. Tell you what has happened at Inova is they have made highly recommended that all workers have the vaccine. Those patients who are pregnant and work at Inova are at increased risk because of their occupation to get COVID. So many of them have a good acceptance, but they're also eligible to get a letter from their OBGYN to exempt them from this mandate. The other aspect we need to keep in mind is that outside COVID, many institutions require vaccination for mandate, for measles, for tetanus, etc. So it's just a matter that the novelty of the coronavirus vaccine is now a concern. Potentially is making this a little bit of a different issue, but vaccines have been for many years out of mandates in many institutions. But currently is for pregnant women, they have the option to be exempt, but as long as they get a note from their OBGYN.
Yeah, I couldn't agree more. Certainly, I don't have an opinion about pregnant women because it's not my area of expertise. But yeah, at the University of Maryland, it's mandatory, and pregnant women are excluded, like it was just mentioned at other institutions. But I think this fear about the vaccine, I mean, COVID is a bad disease. And really can hurt you for a long time. Even, I mean, if you survive, I mean, there are long-term effects. And kids, in fact, have shown that also, the long haul COVID, that, you know, kind of brain fog and chronic fatigue and different things. So anyway, I think everyone who meets criteria should be vaccinated.
Okay. You know, as a follow-up to that, you know, with the Delta variant being so highly transmissible, high variant load, before when we had, you know, the minority communities that had vaccine hesitancy, and now with all the breakthrough cases, how are you dealing with your patients that thought they might want to get the vaccine, but now are probably thinking, what's the point? People are getting, you know, infected. How, you know, what are you telling your patients about that?
I think there are some things we need to tease out. Many of us have forgotten that
Americans are now eligible for the Pfizer COVID-19 booster shot. Well, the CDC says people with pre-existing health conditions.
there is a background recording going on, but I just want to say that a year ago, we were begging for any solution. We were literally begging all over the world. But it just happened that the vaccine was is approved, and then of course natural reaction is the hesitancy to this. So it's interesting how our, as a population, our approach to this can change and be influenced easily by different events going on, and that's worldwide. It's not necessarily here in the U.S. So with that said, of course, there is always some controversy in the inquiry about what's going to happen, especially since this is recent. But we should never lose hope that this pandemic has caused more death than any other pandemic in the past, maybe more deaths than any other war human kind has been involved into. So we're facing a very tough enemy. And as such, solutions have been found relatively soon. they're not the best, and potentially will take a while to get acceptance, but we should never forget what we are facing. We're facing a very tough disease that has killed millions of people, have not respected any age at all, and pregnant women are, of course, very susceptible to this. I have to add, last year, from March 2020 to March 2021, we had 4 patients that require ECMO or ICU. This past August and September, we have 4 patients. What it took us a year to collect, we have had in a month 4 patients with the Delta variant who are intubated. 3 of them currently on ECMO, 2 of them potentially waiting for any bad thing to happen. So this is a real situation. This is not a hypothetical event, can hit anyone. All these patients were healthy, they just didn't get the vaccine. So it is a tough condition to say. The other aspect we need to remember is the vaccine was created to prevent death and hospitalization. It was not created to prevent getting COVID. Not even the influenza. We get the flu vaccine every year, and we still can get the flu, but we don't get too sick to go to a hospital. So that's the other aspect of it. You can have a vaccine that doesn't make you immune to catch the virus, maybe not at similar density, but all those things are lost into the perspective whenever we talk about vaccines.
Yeah, and the other thing to remember is all vaccines have some side effects. And I think the issue about the vaccine has become, it's unbelievable to me that even in the news and the politics and everything else, how sometimes there is so much controversy from people who in reality do not see these patients, do not see the disease. And so if you have kids, at least in pediatrics, if you have kids in your family or your own kids, you know that you gave a vaccine and they will have fever. Even with the pertussis vaccine, you can have a seizure. I mean, but all vaccines, like any other medications of any other sort, we have some side effects. So certainly, we hope, I think we all hope that the population will come more, they will trust the science. And I think there is a lot of misinformation, and it's our role, like it's webinars like this, I mean, and like somebody posts something, is going to be published in Spanish for the, you know, just not for physicians, but for the rest of the population. I think it's important to create trust.
Yes.
Yeah, I just want to mention that at the beginning of the pandemic, the Hispanic population were not very willing to get vaccinated because we have seen with the other types of vaccines like a flu that the Hispanic have the lower rate of vaccinations. But this has been actually increasing according to the Kaiser Foundation that was released just recently. Hispanics now, they have adults, they have 73% they have vaccinated, so they are even higher than the white. So I think the hesitance has decreased, and that's a good news. However, in pregnancy, still we have a lot of work to do. You know, we have only 24% of Hispanic pregnant women are willing to get vaccinated. So it is very important for us as providers that we have to initiate this conversation with our pregnant patients and spend some time in trying to see why the patient doesn't want to get vaccinated. There is a lot of misinformation going on social media with the friends. You know, I ask the patients, why is that you don't want to have the vaccine? It's because I heard something, you know, they say that if you get the vaccine, you are going to transmit the virus to another people. Some other people, they feel for religious beliefs that they are protected by God and they are going to accept whatever happens, so they are not going to get the COVID. I think if we present the patients with the data, what is going on in the actual, this time with the Delta variant, how severe patients are going to the hospital with, like Dr. Gomez was mentioned, he has seen 4 patients with ECMO in 1 month as opposed in 1 year, this is a very serious situation. And we can have more new variants in the future if we don't get the most of the population vaccinated for herd immunity.
Perfect. Thank you so much. I think we've run out of time. So thank you to our panel for their very insightful presentations. If you have any questions, please email nhma@nhmamd.org. And also, we would love for you to become a Vaccinate for All champion. To learn more and sign up, please visit nhmamd.org/vaccinate-for-all. Thank you very much and have a good evening.
Thank you. Good night.
Thank you.